Hello, very good morning to everyone. And today we are going to see some of the picture based MCQs and spotters and pointers of MRCP part 2. Especially, we are going to see for this dermatology. Because I'm very well aware that there are no quality lectures or anything on them, especially focusing in the aspect of MRCP. And in MRCP part 2, you may get slides. You may get a lot of picture based question, or best of 5 picture based question you may get. So you have to know certain pictures and you should be able to diagnose it, because they expect you to be as good as an internal medicine resident, and some of you may not have got a chance to see a wide variety of pictures, because maybe due to your nature of your job or amount of cases you are going to get in the hospital and all. So today we are going to see little MCQs, and I'm going to show you some pictures which are repeatedly asked by the Royal College. So we are going to go quick run through of some MCQs and some pictures, and I'll give you some tips on how to identify those pictures. Okay, and I know it's going to be 100 plus slides. I may be running through, or I may be rushing, and I want you to pause and take a look at the slide once or twice, again and again, and over, and that will actually help you. Okay, here we go, guys. Need to know here, if I'll go to that slide now. Yeah, telogen effluvium is nothing but it's characterized by increased, like I said, during the telogen phase, telogen club hair shedding. And like I also said, it's the most common cause of diffuse hair loss. It's subdivided into, again, that's like SE level, you don't need to know that. And if there is a differential diagnosis, it's going to be alopecia areata. In September MRCPs, not September, I'm sorry, I think I reckon July MRCP or June MRCP, I think I've seen a question paper where they asked about alopecia areata. In alopecia areata, there will be a term called exclamation mark hair. Exclamation mark hair. If you notice the term, no, that is alopecia areata. Also, alopecia areata, about this, it is associated with one or the other autoimmune disorders, and it's further subdivided into, I hope you know, alopecia areata is further divided into two types. One is alopecia areata totalis, and another one is alopecia areata universalis. Universalis means no hair in the entire body, so you should know this. And in telogen effluvium, you can see a spontaneous recovery as expected, because once the thing is eliminated, the patient will recover typically. This is the most common cause of hair loss. And for that, I would like to show you this thing. This is a hair cycle. You will see stages of hair growth. This is called as hair cycle. See, the first phase is anagen, that's a growing phase, we call it as. Second is a catagen phase, that is a transition phase. Telogen is a resting phase, and most people will get hair fall during this telogen phase. That's what we called as telogen effluvium. And the last phase is nothing other than exogen, that is a shedding phase. And what exactly is a telogen effluvium that we need? They won't ask. If they may ask, this is called Hamilton-Norwood classification of male pattern hair loss. Yeah, more or less you can think this is going to be, number one is going to be how you are when you are going to join the medical school. This is how you are when you are going to finish your super specialty. Here we go. Now we go to the spotters. The first spotters I have presented. Okay, I believe now you will crack through if they are going to ask you anything again. That's how it is. Telangiectasia. See the pictures on side. Very important. This is how it looks. This is nothing other than hereditary hemorrhagic. Our good old hereditary hemorrhagic telangiectasia, or Osler's Weber's Rendu's syndrome. There will be the following findings. First, there will be spontaneous and recurrent epistaxis. You have to answer all these questions. Suppose if you are going to get this case in PACES examination, and there will be multiple mucocutaneous telangiectasia, and there will be definitely AV malformation in GI tract, in pulmonary arteries, cerebral vessels, and hepatic AVM, and all these things will be there. And always there will be like a first degree relative will be with the HHT in most cases. Like the criteria is 3 plus of this if it's a definite, and if they can satisfy 2 out of this, any of the ABCD, you can call them as suspected, and then there is only 1, then it's unlikely. This is little of higher level, you don't need to know, but you should know the slides. You should know how it looks, and that is with this. Now we are going to go to another MCQ. Here we go. Now a 35-year-old woman, she has a facial rash. A lot of reasons for facial rash. You should be aware of a lot of differential diagnosis when it comes to facial rash. That is SLE, that is DLE, there is acne rosacea, all these things you should be knowing. And and she had erythematous scaly indurated plaques on both sides. And see here, there is a scarring alopecia and hyperkeratosis over dilated hair follicles. Not everything will cause scarring alopecia. Among all these things, the thing that will cause scarring alopecia is nothing other than discoid lupus erythematosus. In case of SLE, there will be a non-scarring alopecia. Just know that in SLE there will be a non-scarring alopecia, but in discoid lupus erythematosus there will be a scarring alopecia. So the answer to this question is discoid lupus erythematosus, as suggested by scarring alopecia, hyperkeratosis over the hair follicle. Now we will go to the next. Gottron's papules. This is nothing other than your dermatologic rash, alzine, myositis. Okay. Dermatomyositis. Yes, this is dermatomyositis. This is one of the examiner's favorite topic. There is a diagnostic criteria for that. Even if you don't know anything, you should know what is a heliotrope rash, Gottron papules, that is in the finger pads, and Gottron sign, and minor criteria. This is for dermatologists. You don't need to worry about that, and I've shown you everything in the picture. Just make sure you know this, and it may be given along with some other symptoms or syndromes. Just be very, very careful in diagnosing this. If you get this is a dermatome. Now we go to another MCQ. Here you are seeing a 52-year-old man presented with erythema over the buttocks. 52-year-old man presented with erythema, where it's over the buttocks and inguinal folds and inner aspect of thighs and axilla, almost like all the main interinguinous areas. Okay, and he has taken a course of amoxicillin. Just note it down. He has taken a course of amoxicillin and a for a respiratory tract infection prior to the onset of skin lesions. You have to be very careful when they mention a drug. You should know whether the patient actually got this rash after the drug or before the drug itself. Sometimes they may give to confuse you, and even during PACEs, you have to be very aware when you are eliciting a drug history. Does the rash came after you took the drug or before itself it was there? And there is a well demarcated erythema over again the same all these areas they said. Okay, what is the likely diagnosis? Erythema multiforme? No. Erythema multiforme, how it presents? Rash with different morphology? It's not. Is it fixed drug eruption? It's not. Definitely it's not SJS, you know that, and it's not toxic erythema. This is a symmetrical drug related interinguinous and flexural exanthem. Don't think they won't ask you such things. They can. They are the people who asked things like nodular amyloidosis, which is, I don't even know. It's a very rare condition. Still they asked in recent PACEs exams. Okay, here we go. What is this? There are 4 things I want you to know. Rest of the things you leave. It's due to exposure to systemically administered drug. First thing you should know. And second thing, there will be sharply demarcated erythema. In this condition, there will be sharply demarcated erythema, especially in the gluteal area. Okay. Also, it affects inguinal, perigenital areas as well. Okay. yeah, like I said, flexural and interinguinous sites. It can affect that area, and there will be symmetry, and there will be absence of systemic signs and symptoms. These are the 5 points you should know about this symmetrical drug-related interinguinous flexural erythema. Okay, now we go to the next slide. See this lesion. Look at this very carefully. How it is looking like. How it is looking like. I'll give you a clue if you don't know this. In this lesion, typically there is something called dimple sign or Fitzpatrick sign will be positive here. That is squeezing. If you squeeze this lesion laterally, there will be dimpling in it. That's called Fitzpatrick or dimple. Pause the video multiple times and look at it again and again till you remember the lesion. Okay, that's other than black spot dermatitis due to the allergen uroshiol. Otherwise, it's also known as poison ivy. This has been on a rise ever since the travel opened in UK. A lot of people from South America, after they travel, they will find it. There's a lot of things on that. I'm not going to go in deep with that because I know many of you asked this lecture just right before your Mrcp2 exam, so I want to go on a revision mode. I want to go quite quickly. Now, the next diagnosis. See this? See this lesion carefully. See this entire lesion carefully. Okay, you saw that. Now see here. See the knees and see the elbows. Are you seeing it? Yeah. Now this one. What you can see. Here we go. This one. Once more you see. Take a good look. Take a good look. Or you guys want to see once more? Yeah. I hope you guys got it. This is nothing other than dermatitis herpetiformis. This is the area of distribution of dermatitis herpetiformis. Sometimes if your day is not good, you may get this kind of pathology pictures also. They have asked in MRCP. I am not telling to scare you or anything. This is a picture of linear IgA deposits. There will be IgA deposits. And about dermatitis herpetiformis, there are certain bullet points you guys should know. It is an intensely itchy rash and papillovesicular eruption. And there will be symmetric distribution only on the extensor surfaces. You should know which rash affects extensor surface, which rash affects the flexor surface. I don't have time to tell everything here because I don't want to overload you guys with any unrelated and unwanted information. And there will be dermal papillary collections of neutrophils and C, like I said, granular immunoglobulin A deposits will be there. And epidermal transglutaminases appear to be the dominant autoantigen. There will be autoantibody antigen reaction. Mostly there will be associated gluten sensitive enteropathy. So the first line for the patient is gluten-free diet. In the patient's exam, if they ask you patient counseling, the first thing you will tell is ask the patient to go for a gluten-free diet. Sometimes they may ask you food that has gluten, because gluten, which in turn has something called gliadin. You should go through that, Google and find what are the foods that are rich in gluten. Try to ask these patients to avoid it, because in UK settings you can find gluten allergy diet, in many hotel menus itself will be mentioned over there in UK, where you can avoid this gluten rich foods. Okay, here we go. Another question now. A 51-year-old male, a 51-year-old male presents with a rash that has been present intermittently. See, this rash comes and this rash goes. There is a symmetrical rash over the cheeks and nose. There are multiple papules and pustules. What is the most appropriate therapy? Here they are not asking what is the rash, what is the most appropriate therapy. Now tell me the diagnosis. The diagnosis here is nothing other than, what is that? Acne rosacea. Acne rosacea is the diagnosis here. If you carefully see here, this is nothing other than lesion typically you can see in alcoholic patients will be flashed out. You can see this lesion over here. The first line will be like topical metronidazole, but here the patient has intermittent for the last 2 years it is there, and now they would have tried all the therapy. One right answer you want to choose here, it's going to be oxytetracycline. Tetracycline antibiotics are used for acne rosacea. That's fine. Now let's go to just read few lines about this. Once again, look at the picture. This is mechanic hands in antisynthetase syndrome. Okay, here we go. This is nothing other than PLE, polymorphic light eruptions. This is a classical history of polymorphic light eruptions. It's a photo-induced disease. Photosensitive disorders are like, it's a big group of disorders you can find, like, you can find a lot of disorders in this, and one of the most common is polymorphic light eruption. You have to prescribe them some, high SPF sunscreens and barriers and steroid creams. Everything will work over here. Okay, see these lesions. You're fine. See this lesion. I hope this will, but see the lesion once again here. Hutchinson's melanotic freckle or lentigo help you guys. Okay, here we go to the next set of lesions. Yeah, see here. See the eyes. See where my arrow points out. See this guy's mouth. See this guy's mouth. You want a clue? It's due to a virus. It's due to a virus. See here again. See here. What is it? See here. Again. You got it? I hope you got it. You should. This is nothing other than Kaposi sarcoma. Most people know a lot of things. One of the most common HIV associated malignancy. But there is a reduction now. Now you won't find much of Kaposi sarcoma. But nowadays HIV patients are as normal as just like you and I, because the viral load can become totally null or like completely null. Like I said, it's due to HHV8. I hope you know that. And we will go to the next MCQ. Yeah, I'm sorry, this is quite a bigger MCQ. Just bear with me. I just put it for some reason. Okay. A 64-year-old woman here presents to the clinic complaint of skin infestation. Okay, she says skin infestation for 3 months. Skin infestation for 3 months. She also said first suspected that her skin was infested by parasites. One day after a visit from her son and grandson who was treated for head lice 1 year ago, she complains of skin itching all over her body, which she preoccupied with scratching herself all day to kill the parasites. History is getting a little weird here. She also expresses her frustration with her condition. She is frustrated with what she is going through, and she has brought a Ziploc plastic bag with some dead parasite. This is the clincher of this. Patient brings a plastic bag with some dead parasites, which she has been keeping an evidence, and requests that sample should be sent to the laboratory for evaluation. Despite report of no parasites and review of other systems will be unremarkable. Everything will be normal, and if you can see, there will be linear excoriations. See, I've seen a patient like this, I think somewhere around 3 months. Actually, one of my friend got this patient and he called over me and said like, I got a case like this. And he called like, it's interesting, can you come and ask the guy? I went and asked the guy like what happened. Like he said like whenever he goes to the washroom and whenever he undresses himself for that, he can see fleas flying out of his groin area. And he got couple of fleas that was actually white in color. I've never seen that. He's telling it is coming out of the skin all over, it is flying the moment he enters the washroom. And later we come to know this is something called as nothing other than delusional parasitosis. It's a condition that's a crossover of dermatology and psychiatry. Patients will actually bring something like this. The history will be like this. So be very careful. They'll bring something like this. I saw the case and I will never forget in my life. So here is a big explanation for everything. I'm not going to go through that because I want this to be a revision lecture, so I'll be little fast, so kindly bear with me. Here we go. See this lesion, and yeah, you want a clue? He is a diabetic. See here, see this irregular borders, a waxy type lesion. You got it? You should. This is nothing other than NLD, Necrobiosis lipodica diabeticorum. This is first coined by Urbach. If you are interested in medical history, you can know that. It is also seen in non-diabetic patients. Nowadays, you won't see this kind of lesions in diabetic patients because it's very hard to find these things. And there will be irregular border and yellowish, like I said, in tibial region, and early lesion may mimic granuloma annulare or sarcoid in some cases. Ulceration is the most common complication. You will give topical glucocorticoids. In a diabetic, you won't give systemic glucocorticoids. Remember, the treatment is topical glucocorticoids, and never ever give systemic glucocorticoids. Never ever choose this. The most common lesion, skin lesion, to be honest, in clinical practice in a diabetic patient is nothing other than diabetic dermopathy. That you can Google and find. You can find a lot of images. Yes, it's the diagnosis is erythema multiforme. So what do you give for this patient? It is erythema multiforme. It's an immune mediated lesion, sometimes oral erosion, genital erosion, everything can be there. The best thing out of the option is acyclovir. It will shorten the clinical course, and it will decrease the complications as well, and there is a proven efficacy for this. And suppression of HSV in this case associated to be having a beneficial effect on patient. So the answer is A. This is erythema multiforme. Is an immune mediated dermatosis. This is a classical thing they will ask you, that is a target like lesions on the skin, sometimes accompanied by oral, genital, ocular, everything. If you want, you can know the dose of acyclovir and everything here in the slide. I've mentioned very detailed. Okay, come on, let's go quickly to the take a good look. Take a good look. Yes, and there is another type, is called dermatitis papulosa nigra. Dermatitis papulosa nigra. I'll show you what it is. It's more seen in darker skin individuals. See here, this is a lichenoid keratosis. That is an inflamed seborrheic keratosis. See, again stuck on appearance, but there is an inflammatory reaction here. This is a dermatitis papulosa nigra. If you get this lesion, you shouldn't mark it wrong. Just go through the pictures again once more. What is the answer? Impetigo. Now, what is the option? Among the option, what is the right answer? This is nothing other than fluoxetine. This most people will pick it up. It's fairly a straightforward diagnosis. Okay, this is nothing other than impetigo. Okay, now we go for another set of diagnosis. Okay, again, once more, take a good look at it. Take a good look at it. And here we go. What is this? This is nothing but Mcqs fungoides, cutaneous T-cell lymphoma. Favors the sun-protected areas the most. Okay, most common variant of cutaneous T-cell lymphoma. CD8 cell plays a major role. This is spot diagnosis. Okay, now this lesion. See this gentleman's head. See the lesion here. See this lesion here. This gentleman's forehead. See it carefully. Look at it. Look at it very carefully. See this hands. Again, the same diagnosis. See this lesion. See this lesion very carefully. It's a precancerous lesion. That is one clue I can give you. It is more common again in light-skinned people, fair-skinned people. See here again. You can find here. once again. If you want to take a look at it again and again, you can pause the video and see. This is actinic keratosis. Like I said, it's a pre-cancerous lesion. It can present as scaly macules, patches in the sun exposed areas. It is more common in light skin tone people, like I said. It has a high risk of development into squamous cell carcinoma. This is something I want you guys to know. Field cancerization. It's a new term. It's a term for areas of skin sorry for the type of skin that has a tendency to form squamous cell carcinoma and actinic keratosis. This is a term called field cancerization. Okay, and you can take a look at the lesion once again or over and over again so that you will have this picture stuck on your memory. Okay, here we go. This most people would have got it. Very clean diagnosis. Bullous lesion, fluid-filled blisters. It's bullous pemphigoid. Some points about bullous pemphigoid you should know. Occur in older adults. Mortality rate is 6 to 40% that you need not know. Pemphigoid oral mucous membrane erosions can occur in only minority of patients, but in case of pemphigus vulgaris you can find it more. And this is something you should know. The pathology of pemphigoid and pemphigus vulgaris is very, very favorite for MRCP examiners. See here, subepidermal blisters with eosinophils and inflammatory cells. I'll show you the histology diagram, don't worry about that. And immunofluorescence will show C3 and immunoglobulin G at the basement membrane zone. And IgG again, same thing they've written in the basement membrane zone. You can find it. There is a autoantigen BP180 and BP230 are proteins of keratinocyte hemidesmosome, a basal cell basement membrane adhesion structure. Things you should know here is IgG at the basement membrane. Number one, you should know. There is a subepidermal blisters, you should know. Okay, you should know the treatment, topical and systemic steroids and immunosuppression therapy. See, this is a subepidermal blister of the bullous pemphigoid. This is the histology diagram of it, and this is an immunofluorescence. See, B, you can find dermoepidermal junction. You can see the deposits, and in A you can find linear pattern of deposition of the IgG. You should know this very well. You should know the histology as well. There is no other go. This is MRCP examiner's favorite topic. Now here we go. See this lesion. See this lesion and tell me what it is. See the oral cavity. See here. Of course, it's PV, pemphigus vulgaris. You can find basal area. It has a basal predominance. If they ask you about bullous pemphigoid, that is more in the dermoepidermal junction, linear IgG. See another picture I'll show you. See. Here, this is little different. This is a pemphigus foliaceus. Here you will find it's more on the superficial area. Here the deposits. Now we go quickly. We will go to the other slides before time runs out. See here. See this lesion. You see? See this. See the shape of the lesion. See the shape of the lesion. Maybe this patient is a diabetic. See the shape of the lesion. Shape of the lesion. See the shape of the lesion. Of course. See the shape of the lesion. Of course, you would have got it by now. This is nothing other than granuloma annulare. It's a relatively common disorder, localized, generalized, subcutaneous, and perforating it. There will be patchy like lesion also be there. Basically, the pathogenesis is unknown. It's seen in diabetic people often. That's all about granuloma annulare. Okay. Now we go to the next slide. See this lesion. See this lesion very carefully. Many people would have seen this slide. See the hands. See the scaling. See the scaling. See the scaling. See the hands. How it's scaling. See this chest area. Here I want you to focus on this nails. See how it is. See this lesion. What it is? This is nothing other than psoriasis. And in psoriasis, you should know the types. This is a chronic plaque psoriasis. You can pause the video and take a good look at the lesion once, twice, even thrice till it's fitted into your memory. And this is something called as Auspitz signs. See, the bleeding after the scale is removed. You remove the scale. Scratch and remove the scale. See, there is a bleeding point. This is called Auspitz sign. There is something called Koebner's phenomenon we should know. If there is an injury, the lesion will appear in the site of injury. It's called Koebner's phenomenon. You should know. Please consider this as your task for today. See what is reverse Koebner's phenomenon. You have to learn. And Koebner's phenomenon also can be seen in another condition called molluscum contagiosum due to MCV virus. That's a very common. Most people can very well spot that. This is guttate psoriasis. See, guttate means raindrops, like drop, like guttate psoriasis. You can see this patient's hand. This is a classical guttate psoriasis. This is erythrodermic psoriasis. This is an emergency. You know, the patient has to be admitted if they come with this classical finding, erythrodermic psoriasis. Take a good look at it. And nail changes in psoriasis, there are so many changes can be there. Proximal matrix, if it is onychorexis can be there, leukonychia if it affects the intermediate matrix. If distally, it can thin the nail plate, and the nail bed there is something called oil drop sign, that is a subungual hyperkeratosis. And you don't need to know all these things in details. This is little of subspecialty level, but at least know how the nail gets affected in psoriasis. See, this is a distal onycholysis. And oil drop spotting. See here. This is a nail pitting. This you would have seen. This is subungual hyperkeratosis of psoriasis. See here. This is a subungual hyperkeratosis of psoriasis. This is onychodystrophy. Total nail is dystrophy. Dystrophic nails. This is onychodystrophy. Here is how you approach the psoriasis. Okay, you should know how to approach psoriasis, because lot of people get confused here, because so many different questions. You should know what is the first line. At least you should know what is a mild psoriasis, what you do. Less than 10%. First line is always emollient. You give glucocorticoids and calcipotriol, like vitamin D3 analogs you can give. Second line you give salicylic acid, tazobactam you can give, and tar you can give. If it is going from mild to moderate, that is more than 10%, if it's get affected, you go for narrowband UVB or broadband UVB also you can go for. And second line is PUA. Then ultimately, if it is going to be more than 30% of your body surface area, if the patient's body surface area is affected, then you go for all the systemic therapy. Everything is explained neatly in this table. You can very well go through that. Okay, woody grain appearance. Take a good look at it. Yes, this is erythema gyratum repens. It's a serpinguous lesion. It's associated with malignancy, like I said. It has a woody grain appearance. It's also called as Gamel's disease. And 1/3 of the patient will show eosinophilia here, and most commonly associated with cancer. Most commonly with lung cancer, followed by esophageal cancer. You should know this lesion very, very well. And here, another set of lesion. Take a good look at it. Okay, now take a good look at it. This lesion is crystal clear. Mostly in extremities and trunk it will be there. Okay, and one more clue. It's a chronic condition. Okay, it has a recurring, remitting, relapsing course. Okay, this is nothing other than erythema annulare centrifugum. This is an uncommon inflammatory disorder. It's not so common, but still it can be asked. There is nothing like only common conditions you will be asked. If it can be asked. Just take a look at it. You don't need to know much theory about this. They won't ask you about your pathogenesis or anything. But treatment, as usual, topical corticosteroids, vitamin D analogs, and antifungals you can use here and here. Now, see this. This patient may be, how I would say, increased blood sugar levels, maybe due to some tumor. Any clues? Anything striking in your mind? Maybe due to tumor in pancreas. I believe some people would have got it. This is nothing other than necrolytic migratory erythema. This is necrolytic migratory erythema. This, it's seen in glucogonoma. It's a painful, eroded, crusted, intragenous lesion. Okay, half of the tumor are metastatic at the time of diagnosis. There is a syndrome called pseudoglucogonoma syndrome that can occur in the absence of this. Kin improves with the treatment of underlying nutritional aberrations. Okay, yeah, here we go. Glucogonoma syndrome. This is again necrolytic migratory erythema. Same patient. Just take a look at this. Okay, fine. Now see this lesion. How it's looking like? Looking like some kind of fire burning. It should give a clue for this. See this again, netted like some kind of fire burning thing. Of course, it happens due to long-term exposure to heat. Now you must be knowing what it is. This is nothing but erythema abygne. It means redness due to fire. Erythema means redness. It's due to long-term exposure to heat, like I said, and treatment is eliminating the source. Just eliminate the source, it's fine. Topical retinoids can be tried if it is so disturbing and the patient wanted to be removed and it's not going, it's kind of getting chronic. You can use NDA glycer. Okay, histology. See the history, see the histology. Recurrent painful erosions for 6 months. What this could be? Row of tombstones, acantholytic cells, IgG deposition. Of course, this is pemphigoid, and so what you will expect here? Anti-epithelial, obviously, surface cell surface IgG C3 deposit in epidermis. This histological picture has been asked twice so far in the last 10 years in part 2. That's the reason I had put this. Here is your answer, and that's the end of our session today. It's far quicker session. I just rushed through the slides. I'm sorry for that, because this is especially for the people who have wanted to go through a quick part 2 dermatology slides and a couple of questions. Just this is a very quick revision just for the people who are just going to appear before exams. Much more detailed sessions we may have it little later. Maybe one more radiology session we can have, and one more session as requested by people on CPAP and all this BiPAP, IPAP, EPAP settings, that we can have one more other day. Okay, I hope this was helpful, and I believe you all guys who are going to appear for the examination will clear out with flying colors and get all set for paces and clear the exams and settle better in your career. And may God be with you, and all the very best. Okay, take care guys. Bye bye, see you.